Empathy is knowing our own dark
Words
knowledge.
have power. Like
Without that connection, you don't have anything.
What's the opposite of addiction?
Just freedom.
Well, hello everyone. Welcome to another episode of Finding Peaks. I am your host, the best of hosts, Chief Executive Officer for Peaks Recovery Centers, Brandon Burns, joined again today by Jason Friesma, Chief Clinical Officer, Clint Nicholson, Chief Operating Officer. Nailed the titles. I messed that up a few episodes ago with Dr. Ryan. I called him the Chief Clinical Officer.
He loved that.
Yeah.
And
it is not a promotion.
He just had
It's lateral?
shaking of his head that was not approving in any way. So welcome back, everybody, though. I'm excited to be here. One of the things we've been talking about, across Finding Peaks episodes, we've kind of just been dropping it in there a few minutes at a time, is this notion of addiction and removing it as language from our industry and the benefits that would follow from that. We want to hunker down a little bit more into that concept today and focus in on why we are trying to push that language aside and really make a claim that this is a mental health issue and it is not about the drugs in that way. And I've been talking about it with our leadership team, trying to throw this out. I'm gonna hit the kids at home. Have any of you seen the movie A Scanner Darkly? Yes or no? It's one of Keanu Reeves' best monologue movies ever made. Anyways, I'm not recommending the movie because it is deep and it is dark and it is about drugs and addiction and a variety of these things, but there's this scene when they pull over to the side of the road and Winona Ryder's in the movie, Woody Harrelson, Keanu Reeves, all the best people, and they're pulled over and the car is broken down and Keanu Reeves gets out of the car and he goes, "We got to stop doing the drugs, it's messing with our brains." And Woody Harrelson walks over and says, "Man, it's not about the drugs, don't blame the drugs." And so I want to use that clip as the sort of transition here that I feel strongly about what we talk about when we say push this word addiction to the side and let's talk about it as mental health, because the drugs is this external thing. It's a feature of our internal condition and why some people use it more than others and why people become addicted to it, differentiates across the public and our culture. And for those reasons, it feels like it's not about that. There's some condition. I think even when we go to, Dr. Alardi's tapes a few weeks ago and the work we were able to do with him, that dopaminergic effect is lacking in individuals at times compared. So one person can have less of that effect than another person. So this person experiences the world in sort of a more mundane, less excited way. When I look at the mountains, I get a dopamine kick. When that person looks at the mountains, they don't. We both arrive to a party that night and we both do drugs. And yeah, I get excited about the drugs, but I put it down. And for this person, in the way that I look at the mountains for that episode, they're now excited about it in that way. And now they have that effect. And what we gathered from that is that this person over here is more vulnerable than the other individuals and more susceptible in that way. So again, it feels like there's a prior condition. It could be trauma, emotional dysregulation, a variety of different fancy words in the clinical world that you will have better access to explain than I do. But let's keep moving that needle in that direction because it feels important, and I think it feels important for what we do as a treatment center. So I know, Clinton, you are most prepared at any given time to want to dislodge that word from the culture, and so I think let's just do some foundational stuff, catch all the kids and the families up to speed on why we're talking about this, and so why do we need to get rid of this word?
Okay, so getting rid of the word addiction. Well, let's start with the stigma, right? So there's a huge stigma around addiction, and the way in which we've talked about addiction and treated addiction culturally for really the last 100 years is that it is this sort of, it's a treatable disease, but is terminal, and it's in the sense that once an addict, always an addict. Also that it is about, there's a sense of willpower that is sort of talked about in the sense that there's a lack of that willpower or a lack of real agency for if you do have an addiction or are an addict. There are moral implications as well, that there is a lack of moral a solid moral foundation that allows you to become susceptible, and that's the reason why you become an addict. There are so many misunderstandings and misinterpretations that have really just sort of muddied the waters, and at the very least made the field of substance use treatment extremely convoluted and very disengaged from the rest of the behavioral health treatment community and treatment world. We've really, when you go to graduate school, you can be a clinical mental health counselor or you can be an addiction counselor. Like there's two separate tracks even though both of these are they're still mental health under the big umbrella, but they actually separate them out and you go down a different track if you go to grad school. And because of that, we have a lot of disparity, I believe, in the way in which addicts are or addiction is treated. And again, when we bring up this word addiction, we're bringing up so much baggage with it that I think what we usually end up doing is spending almost all of our time just going through the baggage and never actually getting to the root. If you think about substance use, the reality of substance use is it is first and foremost a coping strategy, right? It's a way of coping with the world. Mm-hmm. And it's just a very maladaptive one.
Right.
Yeah. Also very effective, right? It's immediate, it's consistent, and it works.
Yeah.
Also, it destroys your life in the process. But it's a coping strategy. Just like anything else in the world is, just like hiking is a coping strategy, right? Deep breathing is a coping strategy. Yeah. Drinking is a coping strategy. Right. They're all along the same lines. But because we have this concept of addiction, we treat this coping strategy differently, and all of a sudden, the use of that coping strategy becomes the individual's identity. And I think that's where we, again, run into another huge barrier.
Yeah, and in a couple inserts there, for folks at home that don't see it as a coping strategy or a reasonable coping strategy, I think there's, I'm just going to call it half of Americans sitting in their offices, their cubicles, whatever at home today thinking, I'm going to get that drink tomorrow on Friday night.
Absolutely.
I've been working my butt off all week. I'm deserving of it. I'm going to go home, I'm going to chill, I'm going to have a six-pack, I'm going to lay out, I'm going to watch the game. Got a lot of playoff things going on. In those sort of ways, we don't talk about it as a society, but we are literally using that opportunity at the end of the week, that happy hour session or whatever, to cope with the things. And we almost create a narrative that we're deserving of it.
Absolutely.
On top of that, right? As well too. And then another pivot into, I always talk with patients at work, who at least make it to my office, and I love running. But I think for anybody who would see a common runner down the road, I think we look, okay, runner, they're healthy, they're doing a healthy thing. I think we've looked at runners in society and said, that's really unhealthy. At some point, we become sickly because we run so much, and there's consequences associated with that. I think we look at people who are, muscular, and we see that as a healthy thing and a coping mechanism. But then we look at some people who are muscular, and like, I think we've exceeded this as a reasonable coping mechanism in that way. And so just wanted to, I think, highlight just some examples for those who might disengage already from the episode and thinking that it's not a common.
And to your earlier point, right, this idea of vulnerability. I mean, there are people that can have a glass of wine at night as part of a coping strategy, right? It's a way to sort of release, kind of come down from the day, to just sort of relax, help enhance your meal, what have you. And that is a perfectly adaptive coping strategy, right? However, there are those with susceptibilities and vulnerabilities that do not have that same adaptive approach to substance use. So the coping strategy becomes maladaptive, right? But they're both, regardless, still coping strategies, right? It's still a way of processing, engaging, or sort of coming to terms with the day or with your life, sort of through external means, essentially.
Got it. And I don't know how much you want to piggyback off this or state more about it, but I think, in the past episodes we've done together, you've parsed out how, Jason as well too, how we've gone from not just addiction of drugs and alcohol, but then there's sex addiction and there's gambling addiction and all of these other addictions that are starting to take place. And really at the end of the day, I think it seems more reasonable to draw it back down to, these are all potentially coping strategies.
Absolutely.
But the way that we're actually looking at, they're maladaptive coping strategies. And when we start using other language, it feels more reasonable and sensible to stop stating addiction. That is the case.
Yeah, and I think the coping strategy implies that something needs to be coped with, which is, I think, what you were talking about as well. And you listed the kind of process addictions, if you will, and then substance addiction. When we begin to look at it as a maladaptive coping mechanism, then we can see that those behaviors a person isn't functioning very well with those behaviors. We get to dig deeper and figure out what is driving that, and then also install kind of healthy coping mechanisms rather than viewing the addiction or that behavior itself as the primary issue.
Mm-hmm. And then identifying that individual as an addict, right?
I was going to mention that too. Because that word addict, which it's such a shaming word.
Absolutely.
And that's that's me getting into the counselor piece, but it's a pejorative. Like, it is meant to look down on somebody, and it is meant to look at some sort of moral failing or something like that someone has incurred, rather than just kind of recognizing that the coping mechanism somebody went to just turned out not to work very well for them, even if it did help them to deal with whatever was driving the issue.
Absolutely. And I mean, and there's complexity to substance use as a coping mechanism, or an added complexity, because there is a physiological impact, right? Yeah. And so then all of a sudden, so it does become more complex to a certain degree, rather than something like, deep breathing, right? Because you do have these physiological components where you start to develop things like dependence, you suffer from things like withdrawals. I mean, so there are complexities to it. At the same time, I think when we talk about adaptive and maladaptive coping strategies, again, we choose to look at the behaviors and then the underlying reasons or motivations towards movement towards those behaviors. Mm-hmm. And that allows us to, again, really dig deep and really get to the core of the issue, rather than getting stuck on these sort of like moral failings or these labels or kind of pejorative identities.
Yeah, to the physiological, brain aspect and point of it too. I mean, one, thank God for neuroplasticity, at least in this moment. There is an opportunity to create new neural frameworks around what is already formed in that regard. But, the thing that I think I want to say about it and the challenge around it is that even though that's there and it's maladaptive as a coping mechanism, the person is suffering, and so they want to deploy skill sets into the world that will alleviate that in some sort of way. And to me, that nagging physiological brain state is just a strong tug in that direction, because we've told the brain every single time. I brought it up several times on this episode, I got a trigger, I insert a drug, I got a trigger, I insert a drug. Well, you take away the drugs, you're still being triggered at all times. And then where are you putting that energy to, over time, help and heal the brain in that sort of way? So I certainly don't want to take away, I don't think any of us do, that there's this nagging brain state now left over from the events over time that have caused what we call addiction today. But to be clear, it's a pull in a direction of maladaptive behaviors, right? Rather than it being the core issue. It starts with the core issue, the thing that needs to be supportive, the trigger, and then the tug in that direction. So without putting too many words on it, like, that is correct, right? That is the...
What I think, as you were talking, Brandon, I was just thinking about how, if we kind of look at depression, I find there to be a significant parallel how when somebody is depressed, it is really hard to get out of bed, and sometimes they don't get out of bed. And we can judge that all we want. And I think that's where we begin to find some correlation that, like, depression, other anxiety, other mental health issues have behavioral components that make us feel like, hey, if you just stop, get out of bed and you'll be okay, or stop pacing, or just go to sleep at night, or whatever. And when people are really wrestling with other mental health issues other than substance use, there can still be that these underlying behaviors that still need to be addressed, and then the underlying issues underneath them. And for some reason, it's really easy, I think, for us to be like, okay, somebody's depressed. Let's find the thing in the items that are kind of driving that depression and the behaviors of not getting out of bed. But we've lost some of that curiosity with addiction, although I think it's coming back, or with substance use disorder. Sorry.
Absolutely.
Yeah.
Great correction.
Thank you.
Good save.
Good save.
I was shaming you.
I was just shaming you.
We have to do away with the word.
Yeah, exactly.
At some point in this episode,
we will
as well
bleep
too.
it out. Can we just start bleeping it?
Yeah.
Like it's a bad word.
Yeah. So when we trauma and somatic experience and all of it could be a whole nother episode in and of itself, but it seems like there is a major bent toward trauma as integrated care within treatment episodes in that regard. And I think that's telling. We get a lot of phone calls to Peaks and people say, oh, well, they didn't deal with the trauma in the past episode. That's why these things continue to occur. If we're translating that right, it's person experiences something, trauma caused emotional dysregulation under certain conditions. They experience that moment, and then that strong tug in this direction pulls them back into that addictive cycle in that way of things. But if that's true, again, then we're working on the mental health issue. That is trauma, a dimensional 3 ASAM criteria, not the drugs in and of itself, right? There's no therapeutic intervention of like, let's create, kind of like what EMDR does, maybe a backward dive into an awareness around the trauma. Like, we don't bring the drugs front and center in that regard. I guess some treatment protocols might call for that in some environments, but again, it just seems like it always reverts back to a causal, rudimentary mental health issue, and then the drugs are an external maladaptive strategy to that internal issue. It never feels like, in all of the times that I've met patient care and family systems, that the thing we're working on is that physiological brain state.
Right.
And we work on coping strategies around those cravings because they do exist at the end of the day, but even that seems to get away from it being about the drug itself.
Yeah. Oh, I'm sorry.
I was just going to say, I can think of people very, very recently at Peaks, who literally, it seems to occur with some of our younger clients who maybe haven't developed some of the other coping mechanisms that we've talked about, but they come in and their substance is removed, and then they're like, I can't stop thinking about my trauma. I'm just getting these flashbacks, or I don't. Like, the correlation is blatantly obvious with some people that maybe are a little less defended or don't have other kind of strategies for dealing with it or for masking their trauma. Like, there's some people that just literally are like, I quit using or I quit drinking, and all I have is trauma, and this doesn't make life worth living.
Right.
We look at those people in the eye all the time.
And those people oftentimes once you've taken away that coping strategy and you sort of exposed the wound underneath, whatever that wound may be, that's also a really high risk time for people to run, right? Like for leaving against medical advice or against clinical advice, because all of a sudden there's exposure, right? And because there are no coping strategies or adaptive mechanisms that have been added to sort of help soothe and help the person sort of cope with those really highly acute and really overwhelming emotions, the brain literally tells you to go and do drugs because that's what will make me feel better. And that's the really tricky thing about substance use as a coping mechanism. There is that physiological tug that takes months, years sometimes, to actually to mitigate to the point of where the risk of relapse is actually significantly lowered. It's also what makes substance use and one of the most highly acute mental health diagnoses, because there is this physiological component to the coping strategy that has to be dealt with alongside the clinical or behavioral health, emotional component, psychological component. And trying to do those two things at the same time becomes very complex. It's very difficult, and it's one of the reasons I think that the treatment in general for substance use, if they're not treated at the same time together, is so unsuccessful.
Yeah. And maybe you guys can help me out with this analogy. It's been a while before I've thought about it, but it's coming up for me here. And this, like, diabetes is often like a sort of side-by-side analogy of addiction, and we have two individuals in need of stopping, one using drugs and one eating in a certain way, or needing to readdress their lifestyles to maintain a healthy life moving forward. And curious from your guys' perspectives how accurate that is, because I believe I've heard it in some conferences and some special settings before, but also as well too, that what I hope to do is diffuse this notion of like, it's the drugs over here, because for the diabetic over here, it's this poor eating habits and it's these foods. Well, for both these individuals, the diabetic has to figure out a way to move away from those behaviors of the foods that are causing disrupting the insulin levels and all that sort of thing within the body. But for that individual as well too, there's a reason in which like those food eating habits have become maladaptive, and they need to find those better suited ways, especially with this new condition, for going about their world that's in front of them. So I bring it up because, again, as a mechanism of diffusion of these external things, when really you have this internal suffering in the individual. And just as difficult as it is to ignore that tug, the diabetic still has to ignore that tug towards the unhealthy eating habits.
Yeah, I think, to be clear, it's type 2 diabetes you're referring to.
Okay, not type 1.
Yeah, type 1.
Let's get that in there.
So
You're bored with.
yeah,
Yeah, type 2.
Just to be clear, and I've heard the same metaphor, and because I think the metaphor comes from, that type 2 diabetes, there's a component that is behaviorally driven, right? Like, and it can be behaviorally controlled. Earlier in my career, I worked for a pharmaceutical company, Eli Lilly, who actually, I believe, is the company that developed insulin first. And so they, out of Indianapolis, and they still are a leading researcher on diabetes medication. And so part of our training, we had just tons of patient information and behavioral interventions and all this mental health stuff that we would provide to endocrinologists and primary care physicians, because compliance with a healthy diet, or even just taking insulin or measuring blood sugar, was quite low. And oftentimes people would change their behaviors as soon as they started to feel better, or rather than realizing that it was the meds that were helping them. And so I think the metaphor makes a lot of sense in a lot of ways. And then I think in other ways it doesn't make sense, but I'll volley it over to you, Clinton.
Wow.
That was more of a spike.
Yeah, it does make sense. Go.
Yep.
Yeah. I guess where the hole in the metaphor for me is, at what point do you ask the diabetic, why are you eating like this, right? Like, why have you developed a diet that has led to what is noticeably negative consequences, and continued to engage in that diet regardless of the fact that you know that you're hurting yourself, right? That's, to me, at that point, and unless you ask that question, you lose the metaphor. But I think once you ask that question, all of a sudden you've started to align with somebody who struggles with substance use, because you're looking at maladaptive coping strategies, right? But you don't get to a maladaptive coping strategy until you ask for the question why and get to motivation, right? That's, if you don't know what you're coping with, then you're not really talking about coping strategies anymore. And it comes more towards, again, it's a moral deficit, it's a lack of self-control, it's a lack of willpower, lack of self-respect. It's all of these very shamey narratives that start to pop up. And so I think that when you get rid of, going back to the original question, right? When you get rid of the word addiction, or when you get rid of these sort of very, and the word addict, you eliminate the shame shadow, right? And all of a sudden you can start to see things much, much more clearly, because it's just about seeking out, why is the behavior, what need is that behavior meeting, right? Really building insight into that motivation, and then slowly over time developing alternative coping strategies that are much more adaptive and that more align with the person's well-being and their desire to get better, right? Things get very clear at that point, right? Mm-hmm. And all of a sudden we're not caught up in this 100+ year narrative of, oh, well, I've lost all control in my life and now I need to hand myself over to a higher power in order to regain it. It's like, the higher power component is actually meeting a different need as well. That is really that is probably to some degree, when it works, answering part of that "why are you doing this" question, right? But again, I think that we complicate things,
Right.
right? And addiction and addict as concepts are more than anything just complicators.
Yeah.
Yeah.
And we've done, kind of trailing down to the end of the episode here, we've talked about it, not that this should be language that's continually deployed in the world, it's certainly shame-based, but out of the rooms comes this language of the dry drunk. And the individual who's been absent of drugs and alcohol for some time period, but has this sort of, my reel from it is that there's significant emotional dysregulation still. There's still anger, there's still shame, there's still sadness, there's still all these other sort of things. And I think the language should not be used, but for the sake of the conversation, it's pointing at the real problem.
Absolutely.
In the absence of alcohol, I still have to live with this.
Yeah.
I still have to live within this world.
Right.
And people are looking at me in a way to get this terrible language, dry drunk, because I may be without alcohol, but I seem just as miserable as if I were on alcohol.
It's white knuckling,
Right.
is
Yeah.
another term, right?
Or the coping mechanism just shifted from alcohol to AA without addressing any of the actual root cause.
Right.
And then not to discredit the 12-step world
At
and
all.
the 12-step process, because that can be part of the coping strategies that replace the maladaptive ones. It can be very adaptive and also help to really develop insight. But it doesn't necessarily get to the very heart of the matter, right? There are layers upon layers that need to be addressed with any mental health diagnoses, right? And stopping at sort of the high mid layer is for some people it's just not enough. For some, maybe. For some people they are very successful in the 12-step world and are able to utilize that platform to both gain insight and develop more adaptive coping strategies.
I think we would be remiss too if we didn't mention that there's a stigma with mental health in general.
Yeah, absolutely.
So
Yeah,
like we're trying to
for
get
sure.
addiction just to get to be on par with mental health, but there's already a stigma on
Right.
top of that. Because there is a stigma about being weak if you're depressed or weak-minded around your trauma and all of that. And that part just feels really important as part of this discussion is that we're fighting an uphill battle with this word addiction, but there's also an uphill battle kind of in general with the culture with mental health stigmatization.
Yeah, it's like we're just trying to deal with one stigma instead of two.
Right.
Because
Yeah.
it
Can we
maybe
get to the one?
Let's just drop it down.
And that's important, and certainly we could talk about that at length as well too. But on the way out here, I think that the thing that I want to talk about as well too is because we run into individuals, say, who come to us with opioid use disorder, opioid addiction in the language of it, right? And then we say something like, well, what does drinking look like for you? I actually drink very little, I care very little for it, right? They're explaining whether or not it's adaptive or healthy over here, that it's a non-issue, right? And that the issue is this, but it's a maladaptive behavior for some other core issue. And in that way of things, it feels like what we also want to eliminate, I want to be very careful about this, but addiction in that regard isn't abstinence forever. And it doesn't necessarily have to be that way. And I think this is wildly new territory, especially within a stabilization phase. We're probably not going to talk about this side of stuff. This is aftercare, sort of therapeutic approaches to this. But to be addicted to all things just because of this in this way, even though this thing isn't actually a maladaptive feature in one's life, it seems like it helps us move away from these abstinence-based concepts as well too. And I think the light tone I want to put on it is if I'm 21 years old and I have this opioid use disorder issue and I walk into a treatment center and they say addicted to this and abstinence forever, there's an unreasonableness that if I'm putting myself in their shoes that comes with that. I just turned 21. It's actually not a thing. I can't even remember the last time I drank. I'm just really stuck in this thing right now. And it starts to change the potential for the individual that's in that chair and provide greater opportunities under those healthy coping mechanisms. That if it is the drink in the individual situation in the future, I've dealt with this emotional dysregulation. Instead of going to the bar for happy hour because I'm angry at work, I dealt with that anger about work before I got to the bar as an experience. And I think, is more supportive of individuals, especially young adults who are just in vulnerable positions and have to live the rest of their lives in that way and can't really foresee themselves way out in the future not doing other things that their friends are doing. And the other things that their friends are doing aren't opioids at this time.
Well, and again, I think that just highlights the issue with saying that, well, you have an addiction, so now you're an addict, right? Like now you have this terminal thing that becomes part of your identity that you never get rid of and you'll forever have to deal with. And no matter how old you are, whether you're 21 or you're 75, you will wear this scarlet letter forever. It's really disheartening, right? Mm-hmm. It's extremely overwhelming, and again, like there's a lot of nuance here, but
right.
it's inaccurate in a lot of ways. For some people, that concept of abstinence is just absolutely necessary, and it's what they need, and it's what works for them. And we are in a lot of our programming is rooted in abstinence, right? Like especially at the stabilization period, because the brain does have to heal,
right?
And it is. And there, again, we talk about vulnerability, that you are still vulnerable to replace one with another, like one maladaptive coping strategy with another maladaptive coping strategy, and that could be replacing one substance with another. So all of these risks are very real, and of course, again, a very nuanced conversation, very, it could be pretty volatile, I think, to a certain degree, depending on who you're talking to, but it does highlight this idea of one of the major problems with this idea of addiction is that I have an addiction, now I'm an addict, and I'm an addict forever.
Mm-hmm. And I think one of the charitable takeaways from a conversation like this as well too is that I think the goal in early treatment is not to discourage people about their future opportunities, but to engage them in the suffering that brought them to a program
Absolutely.
like ours in the first place. And somebody comes in and says, I have this opioid use disorder, and we label them as an addict right away. That can be language that will immediately, they'll pull the eject button, they AMA. It's language in the way of the opportunity at times, and that feels full circle to me. Unless, Jason, you want to drop the mic on something here on your way out.
Or just another layup that's
Really
uncomfortable.
Volleyball spike, yeah.
I don't. The only thing I wanted to follow up with was just with the young people, the heroin addict drinking again. To me, if we look underneath that, what drives a lot of addiction, or at least a symptom of it, is certainly this isolation and this hidden life. And so, to me, my language that I've wanted to develop over the last few years in my career too is just, if you're open with people you trust, and it isn't hidden, and then you're honest with yourself about whatever comes up for you along your path, that feels like kind of a way to progressively have those conversations instead of, because unfortunately what I watch in the abstinence culture is, like, if somebody begins to dabble or they want to try an edible or something, we're in Colorado after all, 3 years into their recovery journey, they have to like disappear or hide it. And to me, that's where I think, significant relapse can be fostered, is in that secrecy and silence and all of that. I think, but being open and transparent, to me, feels like the answer to a lot of that.
Yeah, dig it.
Yeah.
And I think just for me, I'm really passionate about this topic, obviously. And at the same time, I recognize that it is, it's a tough conversation to have, and I think it can be, just having this conversation, a lot of people are going to disagree with me. And again, this is a very nuanced topic. And I'm speaking with maybe a tone of certainty, but obviously there's no right answer in this situation. I think that for me, what I hope for is that we have better conversations that are more open, that have more room for curiosity, as opposed to the sort of certainty that I think we've approached substance use and this concept of addiction with in the past.
Yeah, and because of these nuances, and I've stated in multiple episodes as well too, we have the concept of trigger, and we do drugs, and trigger and do drugs. The initial mistake, at least in my belief, around early recovery concepts within treatment is somebody thinks, okay, trigger, it's not going to be opioids, but I can have a drink.
Right.
That's the problem. You're just inserting the new maladaptive feature. It's trigger. emotional dysregulation, go to a therapist, go to somebody to talk to that about, to work through that issue on. And then over time, gives us a new opportunity as the brain heals around the opioid originally to go, okay, I was triggered, I did the deep breathing, got emotionally regulated, I feel good in this moment, now I'm gonna go have a drink. Sure. And I'm gonna do it in a public space, and I'm not gonna hide from it, I'm gonna have support, and then I'm gonna take that experience maybe back to a therapist and somebody of accountability, right? So just parsing that out a little bit so we don't leave the viewers with like, yeah, this has to be done intelligently, and we have to take it quite seriously because people die, resulting from maybe miscommunicating some of these features along the way. At the same time, it's worthwhile, it feels like, to figure out a way to kind of push this language aside and focus on what is the real issue. And for us at Peaks, that's mental health. Mm-hmm. So with that, everybody on the other side of the screen here, thank you for going through this with us. If you've got questions, thoughts, heated concerns about what we just spoke about in this episode, finding Peaks at peaksrecovery.com. We love hearing your feedback. We love even hearing frustrated feedback at times. So send us all of that. Check us out on the Facebooks, the Instagrams, the Twitters, all of those special things. Follow Chris Burns in Peaks Recovery and his journey as he goes about that. A lot of energy, but a lot of great energy around recovery. It's fun to follow in that regard. Join him. I think he's on next week as the host, and then Friesma will be like 2 weeks from now, but it's kind of the mediocre host, so we'll just...
Hate it.
There it is.
There it is. Anyways, we're taking jabs here on Peaks. We're trying to have a good time. Love you all very much. Thanks for joining us. Until next time, signing off.